A very good evening, everyone. Myself, G. Arunagiri from Government Medical College, Tiruvallur, and I'll be hosting this session today. I will heartily welcome our AATRAL Star Faculty, Dr. Apeksha Anand ma'am, and our presenter for today's session, Dr. Aishwarya ma'am. We can start the session, ma'am. Over to you.
I think the crowd is less today because a lot of them finished exams. It's okay. So anyway, for the rest of them, and if there are any newcomers, this session is mainly aimed for the exam going batch. So we are going to be very quick, and it's not going to take much time. And if there are any second years, third years, or the fresh final years, we'll do a detailed discussion in the coming classes in the next coming months. So just try to follow what we are doing. You can start, Aishwarya.
Yes, ma'am. Thank you. Good evening, everyone. This is Aishwarya here to present the case on cyanotic heart disease. A 2-year-old male child master critic residing in Tamra, whose informant is his mother, whose reliability is good, comes with chief complaints of bluish discoloration of lips and tongue since 6 months of age, failure to gain weight and height as compared to his peers since 1 year of age, breathlessness for the past 6 months, and swelling of nail beds for the past 6 months. History of presenting illness. The child was apparently normal until 6 months of age, after which he developed bluish discoloration of lips and tongues, which was insidious in onset. Discoloration was first seen in lips and then followed by tongue, initially mild and then intermittent, now progressed to consistently blue, aggravated by crying and feeding, relieved when mother holds the baby in caressing position with limbs flexed. History of failure to gain weight and height as compared to his peers since 1 year of age. History of difficulty in breathing for the past 6 months, which was gradual in onset, progressive in nature, class 2 NIHA, aggravated on taking food, crying and exhaustion, relieved on squatting and rest. History of swelling of nail beds for the past 6 months, which is progressive in nature. History of increased redness of conjunctiva noticed by the mother for the past 2 months. No history of cough or cold, prolonged fever and hospitalizations, recurrent vomiting or loose stools, yellowish discoloration of skin, seizures, altered sensorium or any abnormal behavior, loss of consciousness, hemoptysis, abdominal distension, fetal edema or puffiness of face, oliguria or any bleeding manifestations. At 1.5 years of age, the mother consulted a pediatrician for the above mentioned complaints, for which she was advised to do a heart scan and was informed the child might have some heart problem, but the mother did not take the scan.
Okay. We'll stop at this. Can you go back to your chief complaint slide?
Yes, ma'am.
Chief complaint. Can you go back? Okay.
Yes, ma'am.
Okay. So she has given us 4 chief complaints, which is starting from the age of 6 months, and then 1 year, and then 1.5 years, right?
Yes, ma'am.
Okay. So whenever it's a cardiac case, so the symptoms depends on what type of cardiac it is. Now we already know it's cardiac because she already mentioned in the history that it's cardiac, right? So, but we will find out why it is cardiac and why it's not respiratory and what type of cardiac it is. So can you tell me with the symptoms, with these chief complaints, why do you think it's cardiac? Aishwarya, can you hear me?
Yes, ma'am.
Okay. With these chief complaints, why do you think it's a cardiac problem and not a respiratory problem?
Ma'am, there is no respiratory tract infections or cough or cold associated with the chief complaints, ma'am.
Okay, very good. I have got some answers from the everybody. That's it. Central cyanosis. Very good. So lips and tongues is central cyanosis. Swelling. Yes. What is that swelling? It's probably, what is it? What is the swelling of the nail bed? What is it called?
Clubbing, ma'am.
Clubbing. Very good. Then he has breathlessness. See, breathlessness is there. Bluish discoloration is there. Why can't it be respiratory? Failure to gain weight is there. They are seen in respiratory also, no?
Yes, ma'am. Lung disorders can also.
Yes. Okay, go to your next slide. Okay, so you have told me that the bluish discoloration has been progressive. Can you tell
Yes,
me
ma'am.
at what age the cyanosis might occur in a cardiac problem? Anybody?
Ma'am, can mostly peaks at 2 to 6 months of age, ma'am.
4 to 6 months. Why 4 to 6 months? Why not before it?
Ma'am, before it, ductus arteriosus will be present, ma'am,
Very
and
good.
then fetal hemoglobin will also be present.
Very good.
It has increased oxygen affinity, and activity of the child will also be not
Low.
much before that age. So,
Okay. Okay. So whenever you're presenting a cardiac case and whenever you know it is cyanotic, so you should know what age it is presenting and what is the difference between a central cyanosis and peripheral cyanosis. Here you have mentioned that there is only lips and tongue. So the mother didn't say anything about the peripheries.
no, ma'am, she didn't comment much about it.
Okay. So she has given a beautiful history that initially it started and then it has been progressive. So in a cyanotic heart disease, the cyanosis goes on increasing as the age progresses. Okay. So why do you think there is failure to gain weight and height here? Is it related to the condition or is it related to nutrition?
Ma'am, decreased oxygenation to the
Okay, one
organ.
reason is decreased oxygenation. There are a few other reasons for failure to thrive.
Feeding difficulties might be present, ma'am.
Feeding
Child
difficulty,
seeking,
yes. Okay. So anything else? Anybody else? It's a chronic condition, yes. Baby's fatigued, yes. See, there is one more thing that you should know, that there is increase in the oxygen consumption, right? It's a hypoxia, so there is increased oxygen consumption, and there is also an increased basal metabolic rate. So all these things, along with in chronic cases, there will be increased collaterals also. So all these things will cause failure to gain weight and associated with decreased nutrition. So these things are very commonly asked. That's why I'm discussing and giving some time to history, because if it's cardiac, they'll more concentrate on your history. Okay. Sakra suck cycle is not very likely in this one. I will discuss about it later. Okay. Next is difficulty in breathing. So NYHA2. Okay. Can you tell me what is NYHA2?
ma'am, difficulty on breathing at a normal activities, ma'am.
At normal activity, you mean?
Ordinary activity for the child.
Okay. Can you tell me the 4 grades?
Ma'am, class 1 is on exertion or more than normal activity. Class 2 at the normal activity, ordinary activity. Class 3 is slightly decreased ordinary activity, and class
Less
4 is at rest, ma'am.
than at rest. Okay. So see, normally in medicine, yes, we have to write the NYHA classification. In children, it gets difficult for us, right? Child is a 2-year-old child. So how do you tell which is ordinary, which is more than ordinary, which is less than ordinary? Okay. So better not use that term to be on the
Okay.
safer side, because you might get stuck. So you can tell that difficulty is breathing on exertion. That is enough if the
Okay.
child is
Yes,
active. Okay.
yes, ma'am.
Aggravated on taking food, crying, and exertion. Okay. Right. Next. Then history of swelling of the nail beds for the past 6 months. So what do you think this is?
Clubbing, ma'am.
So what is the cause of clubbing here in cyanotic heart disease? Anybody who wants to tell me what's the cause? See, there are a lot of mechanisms for clubbing which I don't want to discuss at this point. So you know all the theories of, yes, chronic hypoxia, right? Here in this, the cause of clubbing is chronic hypoxia. There are multiple theories of clubbing, the vascular endothelial growth factor theory, and multiple. I want you to go through it before your exam, because since you've mentioned the complaint, they will ask these things. Okay. Then next is the redness of conjunctiva. What do you think this is?
Ma'am, due to polycythemia, ma'am, with applications of
Due to polycythemia or anything else? Anything else other than polycythemia? Okay. Anything else? Anybody? Hypoxia, ataxia. Okay. Okay. See, there might be some bleeding also, right? Some internal hemorrhages, so subconjunctival hemorrhages. So that also can cause some redness. So we don't know what is the cause. Okay.
Yes, ma'am.
Next, no history. Now, can you tell me why you have asked all these negative history?
And cough, cold to rule out any respiratory tract infections, ma'am.
Okay. Next.
And then prolonged fever and hospitalizations, infected endocarditis or anything like that.
Oh, can you be a little loud, Aishwarya? I'm not sure if you're audible to everybody.
Yes, ma'am. To rule out the complications, I have asked the
Okay.
negative
What
history, ma'am.
complications is it ruling out? Vomiting.
Ma'am, a thromboembolism or
Okay. Okay. Very good. Okay.
and then edema, abdominal distension for heart failures, ma'am.
Okay.
Already.
So, is cardiac failure common in the cyanotic heart disease or acyanotic heart disease?
It is not much common in cyanotic heart disease.
Okay. Then what else?
And then
Hemoptysis, you have asked. Why will there be hemoptysis? Okay, so if you are mentioning any of the symptom, you should know why you are writing. If you don't know, don't write it in the exam. Okay. So hemoptysis is because of any pulmonary infarcts, any thrombosis of the pulmonary arteries. Okay.
yes,
Okay. And then oliguria.
renal failure is really present.
Okay, renal failure. Okay, it's not very common. So oliguria, abdominal distension, pedal edema, puffiness of face, all these are tried for congestive cardiac failure. So we are ruling out any acyanotic heart disease by these. Okay, right.
Yes,
Okay. Next, so the child has already consulted somebody and they have told that it's a cardiac problem. So normally these kids tend to go to, they do not have repeated respiratory tract infection. Why? Why do you think there is no repeated? Anybody? No, there is no. She has written that there is no recurrent hospitalization, right? Okay. You can go to the next slide and say the past history.
past history, no history of previous hospitalizations, no history of recurrent respiratory tract infections, no history of surgeries.
Yes. Okay.
Antenatal.
Tell me why there is no history of recurrent respiratory tract infection now. And where do you see recurrent?
On left heart involvement will be seen recurrent respiratory tract.
Okay. So anything else? Something better? Anybody else wants to answer? Okay. You should remember that there is something called as the pulmonary congestion which happens in acyanotic heart disease with left to right shunt. So that is the cause for recurrent respiratory tract infection. This tetralogy of fallot, what we are dealing with, is probably is a pulmonary oligemia because the blood supply to the lungs and the pulmonary artery is reduced. So this will not cause recurrent respiratory tract infection. Okay.
Yes, ma'am.
Okay. Lung congestion will not be there. Yes, many of them have replied pulmonary congestion. Right. Very good. Correct. Okay. So we'll move on to antenatal history.
Obstetrics go para 2, line 2, abortion 0, pregnancy confirmed at 4 weeks of gestation.
We'll skip to first trimester. Okay. Anything
Dating standard?
significant? Anything significant in the antenatal history?
The most significant history.
Okay. What do you want to see? What are the significant things in the first trimester, second trimester, third trimester we are worried in a cardiac condition? Just tell me those.
And any history of touch infections, ma'am?
Very good. Okay.
Or any history of drug intake.
Very good.
And then any abnormalities seen in the scan, ma'am.
Okay. Any scans? Okay.
And then history of gestational diabetes.
Very good. And then?
Or gestational hypertension you can also have.
Okay, gestational hypertension. Okay, it's rare, but yeah, gestational diabetes, yes. Okay, your friends are helping you out. So teratogenic drugs, very good. Down syndrome, yes. So any syndromes, any genetic syndromes. So even in antenatal history, you can have those clues. And any cardiac history in the mother, yes, excellent. Okay, very good. So you should know when it's a cardiac condition. I want you all to, whoever has exam, to go through the torch infections and what are the cardiac problems. If it's a cardiac case, which torch condition, which causes what cardiac illness, and what are the cardiac defects seen in the drugs, teratogenic drugs. Okay, I don't want to discuss that in detail. Next, natal, postnatal, anything significant?
No, ma'am.
No. Okay. Next.
Developmental history, age appropriate milestones were achieved. Gross motor walks up and down the stairs. Fine motor draws vertical and circular stroke. Social asks for food or drink, and language 2 to 3 word sentences.
Okay, right. So the child is almost 2 years and it's doing 2 years milestone. So do you think there will be any developmental delay or no? Yes, no.
But mostly
Mostly yes or mostly no?
some growth can be seen, but developmental
See, development also can be affected to some extent. Okay, if the child has
okay.
very severe infection, there is chances that mainly motor milestones will be affected. Okay, and if the
Okay.
child is having failure to thrive, if the weight is less, height is less, okay, so that will again hamper the growth. And if the child has any complications like any stroke, any abscess in the brain, so those things again will hamper our development. So developmental history becomes very important. Our child is just 2 years, so we don't know. Until now, his symptoms only started after 6 months. So probably that's the reason it is not yet affected, right?
Yes.
So
Yes,
one thing. So I'll take the questions in the end so that we don't disrupt the case discussion, and we will go in a flow. So I'll definitely give 10 minutes in the end for all the doubts. Okay, continue.
nutritional history, exclusively breastfed up to 6 months of age. Complementary food started after 6 months. Calorie deficits of 330 kilocalories is seen and no protein deficiency is seen.
Okay. So the child is calorie deficit. So you should
Yes, ma'am.
always remember that diet becomes very important because it's already an increased basal. There's always an increased basal metabolic rate in the body. So the demand is more because of the underlying condition. So you have to be very careful with the diet history. It becomes very important. Okay. Next.
Immunization history. The child was immunized appropriate for age as per national immunization schedule. No
Okay.
additional vaccines were given. Last vaccine given was DPT booster, OPV booster, and MR vaccine. Family
Alright.
history, non-consanguineous marriage, second born child. No history of similar illnesses in the family. No history of congenital heart disease in the family. And no history of early deaths or congenital anomalies in the family. Socioeconomic history, according to modified Kukusami scale, they belong to lower middle class. Lives in Papa house, 4 members in single room, separate kitchen and toilet.
So one more thing, family history. I would want you all to write a pedigree chart in your exam and write properly the family history because a few cardiac conditions run in the family too. So make sure you do that. Okay. Next. Okay. Can you summarize your history? Yes.
Yes, ma'am. A 2-year-old male child, second born of non-consanguineous marriage, presented with history of cyanosis, noticed in 6 months of age, with failure to gain weight and height since 1 year, clubbing and breathlessness on exertion for the past 6 months. His antenatal, natal, and postnatal history was uneventful. The child attained normal development and is immunized accurately. I would like to consider the possibility of a cyanotic congenital heart disease and examine the cardiovascular system.
Okay. So why you think it's not acyanotic? Now tell me because you specifically told it's cyanotic. So I will ask you, can you tell me 4 points why it is not cyanotic? Acyanotic, sorry.
Cyanosis is present, ma'am.
Okay, very good. What cyanosis is present?
Central
Please.
cyanosis is present,
Excellent.
ma'am.
So central if you can tell this child has central cyanosis. Very excellent. One. Next.
And then features of cardiac failure are not seen, ma'am.
Very good. Right. Then.
And then
Anybody else wants to help her? Early presentation. Yes. Age of presentation. Yes. Then. Yes. So age of presentation becomes important here. It started. Yes. No congestive cardiac failure. Clubbing. Yes. No recurrent respiratory stack. Yes. There's no suppressed cycle. Yes. Okay. Right. Very good. So at least you have to know these 4 things in acyanotic and cyanotic. Anyway, tomorrow we are dealing with acyanotic. So I'll discuss in detail that. So for this, you should be able to substantiate why you are causing it a cyanotic heart disease. Okay. Okay. Next, we'll continue with the exam and then we'll discuss.
general examination, the patient is conscious and alert. Central cyanosis is seen. Grade 3 clubbing is seen. No generalized edema, no pallor, no interest, no lymphadenopathy.
So what, no pallor you have written, then what else can you expect here?
Anemia is one of the complications of congenital heart disease.
Anemia is one complication. What other complication can you see? Anybody else? Very good. Polycythemia, right. See, you're writing pallor. I know it's very common, but when you're thinking of something like TOF, you can also mention if the hands and the fingers are excessively pink, right? That denotes polycythemia. You can very well write that in your general examination. It does not always have to be pallor. Okay?
Okay. Yes.
Okay. So clubbing is seen. You have to tell how many digits are there. All fingers, upper limb, lower limb.
Pan-digital clubbing is seen.
Pan-digital clubbing. Okay, so that you have to mention because we want to know. So what are the grades of clubbing?
Grade 1 is fluctuation. Grade 2 is loss of nail bed angle. Grade 3 is paraplegic or drumstick appearance. Grade 4 is hypertrophic pulmonary osteoarthropathy.
Okay. So you should know to examine all these. These are something very basic. It should be asked. Okay. They'll tell you ask how to examine. Okay. Next.
Yes,
okay. Next.
Head-to-foot examination.
Okay. Tell me just the positive points.
Yes, in the eyes, conjunctival suffusion is seen, and in limbs, distal interphalangeal joint swelling is seen, and no deformity.
Okay. So no dysmorphic features. Why do you want to say there's no dysmorphic features specifically? What are you thinking about?
Any associated syndromic associations we are looking at.
Okay. What
like
syndrome?
DiGeorge syndrome.
DiGeorge. Okay. Then anything else? Anything else? Anybody wants to answer and help her?
Down syndrome.
Good. Very good. Downs. Yes. Next. Okay. There is something called as Poland syndrome. There also it is there. Just it's enough for you to know at least Downs and DiGeorge. Okay. Enough. Good. Okay. Next. Okay, hairline is normal. Okay. Right. Vitals.
Vitals pulse rate 110 beats per minute, regular rhythm, normal volume character, no radial or radiofemoral delay. Respiratory rate 30 beats breaths per minute, regular abdominal thoracic in nature. Blood pressure 100/80 millimeter of mercury in supine position. Temperature is for that. Anthropometry.
1 minute. In vitals, 1 second. I would like to add one point. It will be good if you add saturation. Okay. So do you think the saturation is, see, if there's no pulse oximeter, you can say, but it's very important for you to mention saturation, right? What saturation can you expect in a cyanotic heart disease? I know it's a little difficult one, but do you think it's going to be normal?
No, ma'am, it will be reduced.
Yeah, so okay. So, and are you going to be worried if it is low? Yes, no? Yes, no? You don't know. Okay.
Yes.
See, cyanotic heart disease, sometimes 85 to 90 saturation is also there and it will be acceptable. It's because, yes, it's because of the, yes, compensatory mechanism, and the child will be comfortable. You will not even realize. And if you have already mentioned cyanosis central, that means the saturation is already low and it becomes important to mention it in your vitals. Okay. Don't miss it in the exam. If
Yes,
it's not there, pulse oximeter probe, you ask for it.
okay.
Okay. All right. Next, anthropometry.
Anthropometry, height 77 centimeter, minus 3 standard deviation, weight 8 kilograms, minus 3 standard deviation, head circumference 48 centimeter, chest circumference 58 centimeter, and mid-arm circumference 11.5 centimeter.
So how do you interpret this? How do you want to interpret this?
Severe underweight and severe stunted is the same.
Very good. Okay. We are underweight.
Acute malnutrition is also same.
Okay. So that's important, no? Because of the underlying condition, the child is having severe stunting. Okay, next.
Cardiovascular system examination, inspection, trachea appears to be midline, apical impulse seen in left fourth intercostal space, chest wall bilaterally symmetrical, precordial bulge seen, no chest wall deformity, no visible pulsation, no scar sinuses or fistulas, no engorged veins.
Okay.
Palpation, tracheal position was confirmed in midline, apical position felt on left fourth intercostal space, lateral to mid-clavicular line, parasternal heave of grade 2 was taken.
Okay. So parasternal heave was present. Okay. Fourth intercostal lateral to the midclavicular line. Okay. Next.
Percussion, left heart border corresponds to apex, right heart border corresponds to sternum. Auscultation, mitral area S1, S2 heard, tricuspid area S1 and S2 heard, pulmonary area S1, S2 heard with single loud S2 heard. Ejection systolic moment at grade 4, well heard with diaphragm of stethoscope in the third to fourth intercostal space in the left parasternal region, not conducted to axilla and back. Aortic area S1 and S2 were heard.
Okay. So examination wise, what are the positive points here? We have a see. Okay, what is the 4 components of tetralogy of Fallot? Can you tell me those?
Pulmonary stenosis, right
Okay.
ventricular hypertrophy, and
Okay.
then ventricular septal defect and overriding of aorta.
Okay. Okay. So what happens because of the right ventricular hypertrophy?
It is a concentric right ventricular hypertrophy.
Okay, so you should remember that here, normally when the left ventricle is affected is when the apex is moved, right? So what happens here? The right ventricle is lifted up. So what shape of heart do you get it of? What is it called?
Boot shape heart.
Okay, so boot shape heart. So it's something they'll ask you. Okay. Next. So okay. So what is the cause of this murmur? So you said you will have a ventricular septal defect. Is that causing the murmur?
No, ma'am. The VSD is a silent VSD in this case, ma'am.
Okay, very good. So it's a silent VSD. Why is it a silent VSD?
And it is right to left shunt, ma'am, where both the pressures of the right ventricle and left ventricle are identical, ma'am.
Very good. Okay. So here, mainly the VSD is not, shunt is not causing our murmur because of the equal pressures. Okay, there's no gradient to cause the shunt. So this murmur is what? Because of RVOT. We call it right ventricular outflow tract obstruction. Okay. So anything, see, don't worry about the auscultatory findings, right? Whatever you get, it's okay if you're like missing 1 or 2 sounds. Hard sounds is heard, not heard. Sometimes single heard is heard, not heard. So just forget it. At least if you know to hear that one murmur is there, that's good enough. Okay. Next.
Yes. Other system examination, respiratory system, bilateral RNP present, normal vesicular breath sounds heard, abdomen non-tender, soft, no organomegaly, central nervous system, no focal neurological deficits.
Okay. Can you summarize your history and examination?
A 2-year-old male child, second born to non-consanguineous marriage with history of cyanosis at 6 months of age and failure to gain adequate weight and height from 1 year, breathlessness for the past 6 months and swelling of nail beds for the past 6 months. On clinical examination revealed grade 3 clubbing and central cyanosis, polycythemia and injection systolic murmur in the left parasternal region, with single second heart sound in pulmonary region without any signs or history suggestive of infective endocarditis.
Have you written malnutrition? No. So you can write no with severe stunting and with chronic malnutrition, right? You should add
Yes,
that. Okay, that's important.
ma'am.
And development is normal with no history of infective carditis, with no, okay, with no complications. Okay, with no, okay, fine. This is fine. Okay, it's okay. But then you can add that also. Okay, now tell
Yes,
me. Now tell me.
yes.
So, what do you want to do for this child? So, what is your diagnosis?
Ma'am, I like to first investigate the child, ma'am.
Okay, tell me the diagnosis. What is the
It is a
diagnosis?
case of cyanotic congenital. It is a case of cyanotic congenital heart disease, most likely Tetralogy of fallot, with the patient in sinus rhythm with acute moderate malnutrition and no signs of cardiac failure and infective endocarditis.
Okay. So, what do you like to do for this child?
And first, I like to investigate the child.
Okay. How do you want to do it?
Ma'am, I like to do first basic investigations, like complete like hemoglobin, PSR, and blood grouping, ma'am. Then
Hmm.
on specific investigations, the investigation of choice is echo Doppler.
Echo Doppler?
And then,
Please. Okay. Okay. Echo with Doppler. Okay. Okay. So,
and
what are
then
the okay? So, what are the changes you see in echo? You already told that.
on echo, four features of tetralogy of
Ah, exactly. So don't panic when somebody asks what do you see in echo. It is the same four things of the component of TOF which is seen in echo, which you are supposed to tell. Okay.
yes, ma'am.
Okay. Next. Okay. So okay, I will tell you now. No, before going to the management. So one task for you. So you have diagnosed that the child has got a cyanotic heart disease, and you have to explain the mother. So how will you counsel her? So she already knows. They asked her to evaluate 6 months back, but she didn't do it. Now she has come to you, and you know that it is tough. So how do you explain her? How do you counsel the mother?
Ma'am, we'll tell her that this is a heart disease which has been present since birth for the child,
Okay.
and it will worsen. It will progressively worsen,
Okay.
and then we should counsel her for the management, ma'am, like surgery.
Oh, okay. Okay. For your level, it's good enough. So why I asked this now suddenly out of the blue they'll ask, how do you counsel? They know you would have studied everything. So if they ask you TOF, if they ask you clubbing, if they ask you cyanotic, acyanotic, I know most of you would have studied. So they'll jump to such questions. Okay. So okay, before that I'll ask you also a few questions. Can you tell me some other cyanotic congenital heart disease? These are for your juniors if you're there.
Yes, ma'am.
Okay.
Total anomalous pulmonary venous communication,
Okay.
transposition of great vessels,
Okay.
tricuspid atresia,
Hmm.
truncus arteriosus,
Hmm.
Epstein's anomaly, and
Okay.
Einstein-Megas physiology, ma'am.
Nice and makers. Okay. 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 Right. Next, management.
Medical management, management of cyanotic spell, flex the knee of the baby and hug the baby in that position.
Okay.
Oxygen supplementation, morphine, sodium bicarbonate, ketamine. If any dehydration or anemia seen, correction of that, and beta blockers like propranolol.
Okay. Anything
And
else you want to add in the
surgical
medical management? Anything else you want to tell in the medical management?
management.
I have somebody has asked. There's a station for counseling. Can you explain? Definitely, I'll explain. I'll do it in the end. Okay, we'll finish the discussion and I'll take all the questions and I will tell you how to explain because I know every case or anything they can ask you for counseling. Okay, so we'll do that. Okay. So anything else you want to know? Medical? You don't want to support us nutrition?
Yes, ma'am.
Okay, so see, I will discuss it in the end. So you have to write everything in the medical management. Okay, I'll discuss about it. I have few slides for you there. I'll tell you. Okay, next is,
Yes.
so what is the definitive thing you want to
Surgical.
tell? Surgical. Okay, so surgical. So what age can you do the surgery? Corrective surgery.
Uh, After
After two,
6
somebody's
years of
answer
age, ma'am.
6 years. No. See, so nowadays they do surgery as early as 3 to 6 months. Okay, if the child is stable, then
Okay.
they do the surgery as early as 3 to 6 months. So that they directly do the corrective surgery. But if a child comes late with a late presentation, so initially they'll do a palliative surgery. So mostly they do Glenn surgery or a modified BT shunt. Okay, and then followed by
Yes.
they do corrective surgery. Okay, so for your level, this much is enough. They won't ask you in details, but if possible, just go through what are the shunts. But I don't think it's going to. I don't know. I never read at the undergraduate level, so don't worry. Okay. Okay. Now I'll take the questions. Okay, we'll start. So somebody wanted me to counsel, right? Okay. So whenever you are telling about a cardiac condition, so you have to tell what is the condition. So the child, your child has a congenital heart disease. It has probably been there since birth and the manifestations have started. Okay, and then you have to tell them that what is the problem exactly in a layman term. Like there is one hole in the heart and the blood is not properly flowing into your lungs. So all these things are causing him to look blue, difficulty in breathing, and all the other problems he's facing. So there are some complications also associated with it, like thromboembolic events, bleeding, everything. So ideally you have to get it operated. Okay, so if you tell this much is enough, and before counseling always introduce yourself, make the mother and you build a rapport. Explain ECG findings, definitely not required at your level. I don't want to waste time and stress the exam going people who don't know, so I want to skip that. Why cyanosis does not occur before 4 months? Yes, so fetal hemoglobin is one cause, because fetal hemoglobin has higher oxygen level. So that's one things which will help, HbF. Okay, so yes, that is one cause. And also the PDA will remain patent, so this will cause the mixing of the blood. And one more cause which does not happen and is the child is not very active. So basically when there is increased venous return to the heart, so what is the physiology? So increased vein, when the child is very active, how does the cyanotic spell occur? So when the child is very active, there's increased venous return, so there is increased blood in the right ventricle, but it's unable to pump, right? Because of the pulmonary atresia. So there's no RVOT. So the right ventricle outflow tract is obstructed with pulmonary stenosis. So that is why the cyanosis manifests. So knee chest position and all these things which they do is to reduce the peripheral. Yeah. So can you discuss the heart changes in child after the birth? See, this class is specifically not for all these things. I can discuss this in detail. So let us stick on to the exam point of view. I don't want to deviate because there are people going for exams. So I want only clinical part to be discussed. See, conjunctival hemorrhage in heart disease. Okay, so conjunctival hemorrhage, I don't know, maybe. See, normally they don't have hemorrhage. It is the dusky cornea which is seen in TOF. It is mainly because of polycythemia. So, conjunctival hemorrhage may or may not be there. See, any bleeding manifestation can occur because of polycythemia, right? So gum bleeds and all those things. So hemorrhage, yes, the cause may be either anything related to brain, any infarct, which was because of the disease per se. Okay. Okay. Drugs. Anything else you want to know? So we just, can you all please stick on to the exam point of view? Okay, the details, see heart changes in child after birth, all these things. Yes, it's all going to take one class, and I want to finish the discussion between 45 minutes as I promised my students who are going to exam. So edema can increase weight gain. How failure to thrive? See, edema, there's no edema as such in tetralogy of fallot. So weight gain, failure to thrive is one because I told you there is increased BMR. There is increase in the demand for the child. So the hypoxia will cause increase in the demand for oxygenation, and also the child needs in extra nutrition which they are not receiving. So all these things will cause failure to thrive, and also this child does not have any previous hospitalization. So if the RVOT obstruction is very severe, then this would have manifested with definitely a cyanotic spell, and this child has not had any cyanotic spell so far, right? So that means the disease is probably not very severe because it started manifesting slowly, right? So it depends on the RVOT obstruction. So the higher the degree of obstruction, the complications are more, the manifestations are more early, because that's when the blood supply is not reaching through the pulmonary artery. Silent chest in TOF. No, there's no silent chest in TOF. The VST is a silent murmur. So normally VST will cause a pansystolic murmur, right? But here the VSD does not give any murmur because this is a right to left shunt. Okay. And then the pressures in the right ventricle and the left ventricle, the systemic pressures are almost same. So the blood just flows through it and is not causing any sound when it is going. So that is the cause. So that's not silent chest, it's because of the silent murmur. Okay, then okay, squatting equivalence is knee chest position. Okay, what to answer for embryological basis? Yes, they might ask embryology. Yes, you have to read the basic embryology. So you have the truncus arteriosus, bulbus cordis, but I don't think they're going to ask you all that at this level. So just chill. Okay, so I have a presentation ready for you for the last 10 minutes. After that, we can take some more questions. And okay, cardiac versus respiratory. Yes, so cardiac cause versus respiratory cause. So we have to clearly tell. So respiratory causes, there'll be other problems, like the child will have peripheral cyanosis preferably, and central cyanosis is also possible, but whenever there is central cyanosis, that means the disease is severe. So the child will be lethargic, dull looking, tachypnea, and poor feeding, and poor sensorium, grunting, cough, cold, fever. So all these things are symptoms of respiratory. So if there has to be cyanosis in a respiratory disease, that means the illness is severe. Okay, so I'll finish my presentation, then I'll take questions. So I think of queries. Can you all see the slides? Can somebody tell me
Yes,
if you can?
Yes.
Yeah, right. Okay. So classification of congenital heart disease, broadly classified as cyanotic heart disease and acyanotic heart disease. So in cyanotic heart disease with decreased pulmonary flow, our tetralogy of Fallot, tricuspid atresia, and single ventricle. So other univentricular heart with pulmonary stenosis. So increased pulmonary flow is TGA and TAPVC. Okay. Next, acyanotic, left to shunt, right shunt lesions, ventricular septal defect, atrial septal defect, and atrioventricular septal defects, and patent ductus arteriosus, and obstructive lesions like aortic stenosis and pulmonary stenosis. So this is our tetralogy for Fallot. So if you can make out in that picture, so there is narrowing of the right ventricular outflow tract. Okay, then there is aortic overriding of aorta. There is a large VSD and the right ventricular hypertrophy. Okay, these are the four things. Remember. So see, congestive cardiac failure never occurs in TOF. Exceptions are these 5 conditions. One is anemia, another is infective endocarditis, myocarditis, any valvular regurgitation, or systemic hypertension. So the compensatory mechanism in TOF are polycythemia, late closure of ductus arteriosus, and development of collateral circulation. So these are the clinical features. So hypoxemia in the blood, so that will cause the right to left right shunt lesions, which causes most of the symptoms, and there'll be cyanotic spell. Okay, cyanotic spells are more common in the morning and when the child is irritable and aggressive. So there's other problems are like polycythemia, right? So medical management, first to prevent hypoxemic spells, so oral propranolol. Then sometimes there'll be relative iron deficiency anemia also, other than polycythemia. So we have to detect it and treat it. Okay, then so we have to maintain good dental hygiene and to prevent infective endocarditis. Okay, if there is polycythemia, then we might have to manage that appropriately. Surgical may be palliative surgeries like modified Laloc tossing shunt or BT shunt and lens. So complications, polycythemia, central nervous system, they might have abscess, stroke, seizures, hemoptysis, anemia, bleeding of gums, any infections, infective endocarditis, failure to thrive, and arthritis. So the exam going students, please read about cyanotic spell, how it happens, what is the mechanism, management, grades of clubbing, theories of clubbing, genetic conditions causing cardiac defects, antenatal risk factors of cardiac disease, and hemodynamics in TOF. So anything can be asked. Okay, right. So I forgot to ask few questions. So we'll ask Aishwarya again. Can you unmute yourself?
Yes, ma'am.
Okay. So can you tell me what is a pink fallow? Have you heard of the term pink fallow?
Yes, ma'am. Yes, ma'am.
What is that?
Uh,
Pink tetralogy of fallot. Anybody else wants to answer?
Ma'am, when the pulmonary obstruction is not severe enough to cause the right to left shunt, it causes a bidirectional shunting across the left ma'am.
Yes. So pink fallow means the right ventricular outflow tract obstruction is not severe. So there is no manifestation of cyanosis. Very good. So what is pentology of fallot? Is it
Additional atrial septal defect will also be
very good?
present.
So these are the gold medal questions. So if you, it's okay not to know, but it's good if you know. Okay. Okay.
Yes, ma'am.
Very okay. Very nice. So I think we are done with today. So tomorrow we'll deal with cyanotic heart disease. We'll discuss VSD probably. Okay. Okay, there's some doubts. Yes, for less than 4 years, apex is half inch medial to the midclavicle. Yes, it is medial. For less than 4, apex is half or 1 inch lateral to the midclavicular line in the fourth intercostal space. I think it's lateral. Half. It actually goes from medial to lateral. Okay. Anything else? Any other doubts? AST. AST will discuss tomorrow. Okay. AST will discuss tomorrow. My God. So why does polycythemia occur? Polycythemia here occurs mainly because of the compensatory mechanism. Okay. So there is hypoxia. So there is what happens from where do we get our oxygen? From the RBCs. Okay. So there is hypoxia. So to compensate for the hypoxia, there's increase in the RBC production. So this will cause polycythemia. Yeah, so SpO2 and TOF, it depends. See, if there is mild TOF, so it can also vary from 90 to 95%. But I have even seen 80-85% of TOF just walking around and coming, especially if it's long standing, if it's almost 4-5 years old boy. So then the chances that they will have very low saturations are there. So even 80, when I was in Mumbai in a cardiac center, so I've even seen 75, and we can take it normal because it's not going to help it. Right. Anything else? Any other doubts? If not, then we can wind up today's session. Anything else, you can text me personally. See, don't go very much detail into knowing everything for these things. So TOF and VSD are probably going to be short cases for you. I'm not sure. So, and at undergraduate level, they're not going to bother you much about the physiology and what is the hemodynamics, why this is happening, why this is happening. So just know the basics, be very thorough with your history and examination part. It's okay if you're not telling the systolic murmur or if you're not telling the apex properly, but at least apex, yeah, you have to. But if you're missing few murmurs, it is fine. It's okay. So you can tell that I could only hear this. Okay. So I think we are done. Everybody, no more. Okay. Thank you. So tomorrow we'll meet again. So I want all of you to read and come. PSD is a very easy thing. So we'll have more of interaction and finish quick. Thank you.
Yeah, thank you so much, ma'am, for this amazing session. Tomorrow we will discuss acyanotic heart disease ventricular septal defect case discussion at 9 p.m. Please note the timing, 9 p.m. Thanks for joining. Thank you so much.